Does manipulative therapy, home exercise, or supervised exercise benefit patients with chronic low back pain? Let me introduce you to a very well-designed and executed intervention trial that illustrates the importance of pragmatic studies and the feasibility of conducting clinical research in chiropractic college clinic settings. This study was published in 2011 in the prestigious periodical The Spine Journal. The title, Supervised Exercise, Spinal Manipulation and Home Exercise for Chronic Low Back Pain, a randomized clinical trial. The primary authors are Bronford, Mears, Evans, and Schultz. So what's the purpose of this study? The researchers were attempting to determine the efficacy of a high-dose supervised exercise program or spinal manipulation for patients with chronic low back pain and compare their relative efficacy. In addition, a comparison to a low-dose home exercise group was intended to simulate, to some degree, a control group, providing an indirect comparison to natural history. Patients were recruited through local newspaper ads, community posters, and mailings. A time threshold of 6 weeks duration or longer was set for meeting the definition of chronic low back pain for this study. Inclusion criteria were fairly standard. Interestingly, this study, unlike many other studies, included those patients with or without radiating complaints into the lower extremity. Exclusion criteria were a pain score of less than 3, eliminating those patients with minor complaints. Also excluded were any patients with peripheral or aortic vascular disease, those with progressive neurological deficits, those with prior spine fusion surgery, ongoing treatment by other providers, and current or ongoing litigation. Worth noting here is that there are no criteria related to diagnostic categories for low back pain, no inclusion or exclusion criteria related to imaging, and certainly no implication that the results would be compared to a diagnostic group other than the broad category of chronic low back pain. Patients were randomized into 3 groups with 100 patients in each group. Their baseline characteristics were similar. They were randomized into either a high-dose supervised exercise group, a spinal manipulation-only group, or a low-dose group who received no manipulation but were given advice and home exercise. The basis for the high-dose supervised exercise group intervention was based on 2 studies. One, a review by Hayden et al. In the Annals of Internal Medicine, proposed an approach based on their literature review that was categorized by type, program design, dose, and delivery of exercise. The second study, conducted by Bronford et al. In 1996 in JMPT, with, not surprisingly, similar results to this study. Links to both study abstracts are found on the homepage of this video presentation. One strength among many of this study is the clarity of detail and description of how the interventions were designed and carried out. For the supervised exercise group, there was an emphasis on trunk strength and endurance. Utilizing 15 therapists at the Wolf Harris Center for Clinical Studies at Northwestern University of Health Sciences, approximately 20 one-hour sessions were conducted, on average 2 per week. Generally 2 to 3 sets of 15 to 20 repetitions were performed and were individualized to each patient's capacity. Sessions also included a 5-minute warm-up and 6 stretches, including those for the gluteals, hamstrings, and the lumbar region. These were low-tech in that only a Roman chair and gym ball were used. Core strengthening was focused on utilizing trunk extensions, leg extensions, and abdominal exercises as key components. The details for how each was performed is found in the study article. For the spinal manipulation group, standard side posture manipulation was the exclusive approach. The frequency and number of treatments was individualized to each patient. Typically, treatment occurred 1 to 2 times per week, lasting between 15 to 30 minutes. Adjunctive care was allowed, but was limited to only a few minutes of heat, ice, or soft tissue massage. For the home exercise and advice group, patients attended 2 one-hour appointments with a chiropractor and exercise therapist. Self-care was reviewed, including use of ice and heat, ergonomic advice, and demonstration of proper lifting technique. Simple exercises, including stretching and strengthening, were given. Specifically, lumbar extension, bridging, and abdominal curls were demonstrated and reviewed with the patient. Patients were given a book and laminated pictures of exercises and encouraged to perform them daily. 1 to 2 weeks later, the patient was seen again for the second 1-hour session to review the advice and exercises. Patients were then encouraged to continue with their daily exercises. Amazingly, the adherence to the intervention was extremely high, at 96% for patients in the spinal manipulation group and home exercise and advice group, and 86% in the supervised exercise group. There were a number of outcome measures used, including patient questionnaires and objective outcome measurements of lumbar range of motion and strength. Baseline assessment was performed twice, and outcome measures were then taken at 4, 12, 26, and 52 weeks. Here are the self-report measures, which included an 11-point pain scale, the modified Rowland-Morris questionnaire, the short Form 36 health survey, a patient satisfaction measure using a 7-point scale, and a 9-point global rating scale. Although not part of the outcome measures, patients were evaluated for the expectation of treatment outcome based on the type of group assignment. More on that later. Objective measures included lumbar range of motion and trunk strength and endurance. Motion was documented using a CA6000 spine motion analyzer from Orthopedic Systems Incorporated. Strength was measured by computerized digital myograph from Myotech Corporation. The results? Well, the good news, there was a mean change of between 40% to 50% in pain and disability at 12 weeks and 1-year follow-up. This was for all 3 groups. In comparing the 3 groups for both the short-term and long-term follow-up, the only significant difference was for satisfaction, not pain or function. What about other secondary measures such as strength and range of motion? Not surprisingly, those that exercised had on average better secondary outcome measures for strength. There were no differences in range of motion. The researchers also measured patient expectation and statistically compared them to their clinical outcomes. So by taking these expectations and comparing mean outcomes by group, the researchers created 3 categories of much better, better, and no change. Although there was a tendency for those who expected to be much better to improve, the differences were not statistically significant. Importantly, there was no tendency for patients in any of the groups who expected no change in their condition to demonstrate poorer outcomes. A very important comparison was made to what is often considered the most significant measure of success, which is a clinically significant difference. There's no agreement on this measure, although 30% change is oftentimes used as a threshold for a patient's perception of significant change. The researchers chose a higher threshold, now being proposed by other researchers, which is a 50% reduction in low back pain and disability. Using this threshold, the researchers graphed out the proportion of patients who achieved a 50% or 75% reduction in pain, disability, and global improvement. Disappointingly, only about 50% of patients experienced a 50% reduction in pain, and about 60% experienced a 50% gain in their global improvement. For the proportion of patients experiencing a 75% reduction of pain and gain in global improvement, the numbers are even more disappointing. Only about 30% experienced a 75% reduction in pain. About 50% experienced a 75% gain in their global improvement. Although this is great for those with improvement, it certainly is preferred that for the population of chronic low back pain sufferers, the percentage would be far higher. The researchers echo the current cry that the evidence, including that from their study, indicates that the traditional approach of targeting interventions to specific structures has proven less effective than theoretically assumed. They suggest that the only way to make gains on the percentage of those who improve is to shift the model to where the evidence is pointing. This may seem uncomfortable for the standard practitioner, whether medical or chiropractic, but it's clear that for many patients, the source of intractable pain is central. This central processing dysfunction may be addressed through psychosocial approaches. Also, future approaches will target abnormal cortical processing, which is now being mapped and tested. Now, the take-home points. Although there were no statistical differences among the three groups of supervised exercise, spinal manipulation, or home exercise and advice, all groups demonstrated some improvement. The improvement was far less than optimal, with only about 30% of patients in all groups experiencing a 75% reduction in pain. The clear winner on patient satisfaction was the supervised exercise group, even though the outcomes in pain, disability, and global improvement were not significantly different than the other two groups. Which begs the question, are the satisfaction scores higher because of the attention given in the more frequent, more patient-interactive supervised exercise group? And most importantly, from a cost-benefit perspective, is it worth the money to those who pay the bills? The elephant in the room points in the direction of what future studies should be focusing on. Why, for chronic low back pain patients, does a non-manipulative approach with only 2 one-hour sessions of advice and exercise do statistically as well at a 1-year follow-up? Also, why is the percentage of patients who have a 50% and 75% reduction in pain, disability, and global improvement slightly higher in the home group compared to the spinal manipulation group, at least based on this study's findings? We assume that patients doing a high-dose supervised exercise program should fare better than those doing a low-dose home program. Yet, although the strength outcomes were higher in the supervised group, there was no apparent difference in 1-year follow-up for outcomes such as pain, disability, and global improvement. There is a need to compare interventions with a control group or gauge the effect of natural history, although following a patient group for 1 year with no attempt at any intervention is unlikely. We don't know that the assumption of the researchers was true regarding the low-dose group being representative of natural history. It may be that those doing home exercise were very compliant, and this in fact did have an intervention effect. We don't know what care any of the patients pursued over that 1-year follow-up period. It could be that the home exercise group was later seen by a chiropractor, physiotherapist, MD, or others over the follow-up period, and this may have contributed to the 1-year follow-up findings. There is a need to determine cost effectiveness and also value to the patient. The researchers state that this will be published in a cost effectiveness paper in the future. Clearly, in this study, a large percentage of patients with chronic low back pain did benefit from some form of intervention, whether it be exercise or manipulation. The challenge is to find answers for those who did not, even if those answers are found outside of what we do.